Questions of the day, dear viewers. I, Dr. Prajakta Sahasrabudhe, Professor and Head of the Department Cardiovascular and Respiratory Physiotherapy at Sanchiti Institute for Orthopedics and Rehabilitation College of Physiotherapy, Pune, welcome you to today's Physio TV classroom session. Our today's topic is Phase 1 Cardiac Rehabilitation. With increasing incidence of cardiac diseases or all non-communicable diseases, thanks to our today's lifestyle, the need for cardiac rehabilitation is increasing. The heart attacks, the unstable angina incidences are occurring pretty early at the age in working population who are supposed to stay active, participate into their daily as well as job activities, and hence it necessitates the need for cardiac rehabilitation more. So we'll begin with the definition of cardiac rehabilitation. Cardiac rehabilitation is a multidisciplinary secondary prevention treatment modality that reduces mortality and morbidity among patients with coronary artery disease and improves symptoms, functional capacity, metabolic status, depression, and health related quality of life. So, as the definition goes, it is not a job of a one person. So, it is a team approach wherein from cardiologists to cardiopulmonary physiotherapists, psychologists, nutritionists, patient caregiver, everybody is included to enhance the capacity of the patient. So it is basically a capacity building exercise for the patient, along with secondary prevention. That is, the disease has already occurred in them. With secondary prevention, we are going to reduce the mortality, morbidity associated with the disease, as well as we are going to reduce the chances of future such events. So that is secondary prevention. So cardiac rehabilitation is going to help with that. In coronary heart disease, it is going to improve the symptoms of the patients, of course. Since it is a capacity building exercise, it is going to enhance the functional capacity, metabolic status, and it is also associated with, since patients' participation and activity is going to increase, it will be associated with improved psychological symptoms and hence overall improvement in the health related quality of life. Objectives of overall cardiac rehabilitation are reduce mortality, prevent recurrence, improve functional capacity, enhance participation, and enhance quality of life. So all these things we have already seen in our definition. And core components of cardiac rehabilitation are patient assessment. So whenever we are going to aim at a customized plan for the patient, every patient, uh, although we have to get them back to their normalcy and we have to control the risk factor burden, symptom burden for the patient, but every patient is unique. Their demands are going to be unique. So with respect to the patient specifics, we have to do the assessment so that we can make a tailor-made protocol for the patient. Second and most important thing is exercise training. We are going to see why. Risk factor modification, which is a crux of your cardiac rehabilitation, nutritional counseling, psychological counseling, and overall counseling for physical activity, because we are speaking about a behavioral modification over here. It is not that we have given a protocol for 12 weeks, 16 weeks, 20 weeks. It is a lifestyle modulation or adaptation patient is expected to do. So it requires a long-term adherence. And with respect to that, the counseling and psychological aspect or psychological counseling also has to be part and parcel of the cardiac rehabilitation. Uh, if we speak time frame wise, we can split it into four main phases. Phase one is in hospital patient phase, wherein patient either had an episode of myocardial infarction, or they have recently undergone a coronary intervention like PTCA, or recently is operated for uh, coronary artery bypass grafting or CABG. So, although cardiac rehabilitation was initially developed for coronary artery diseases, it is now extrapolated for other cardiac diseases. So, It is not restricted only after CABG. It is also a mainstay of treatment after valvular replacements, intracardiac repairs after in congenital heart diseases, or even in cardiac myopathies or cardiomyopathies and heart failure. So phase one is in hospital period, wherein immediately after the event, patient is in maximum protection phase. So obviously, the risk of having any complications or adverse events is the highest, and patient will be with utmost monitoring and with good medical care. From here, when patient gets discharged, so it is your post-discharge but pre-exercise period. So patient is discharged from the hospital. The patient doesn't require that extensive critical monitoring, but still they are supposed to take slightly slow so that their heart heals. So again, in this phase, we are not going to work on enhancement of the functional capacity. We are not going to overload the heart or overload the systems in order to get the gains. So whatever our phase one goals, we are going to continue with those so that patient is functionally independent. They can manage their own self-care activities. But in as compared to phase one, they do not require the monitoring or supervision throughout. From here, when patient moves to phase three, which is exercise phase and education program, but this is a supervised OPD based phase wherein patient walks into the cardiac rehabilitation OPD, wherein they would be constantly monitored. They would be given some aerobic exercise, which would be incremental in a way that the heart load or the intensity of the aerobic exercise might be changed over the period of time. And then you look at the and throughout the time, the patient would be monitored through continuous ECG so that if there are any ST segment changes, latent changes of ischemia, they would be picked up early. This is basically to make sure that when we are loading the heart gradually in order to increase the functional capacity of the patient is not landing up in any adversities like arrhythmias or sudden ischemia or sudden cardiac arrest. So to prevent all these things, we are making sure that patient is exercising under our supervision with good amount of monitoring. And from here, when patient goes to phase four, it is a maintenance phase wherein patient is continuing with good amount of physical activity without supervision in order to prevent the future episodes or future events. Uh, in our today's classroom, our main focus is phase one cardiac rehabilitation. So we are not going to speak about other three phases. We are going to stick to the phase one cardiac rehabilitation. So as I have explained earlier, that it is inpatient hospital rehabilitation. So typically, any cardiac patient where whether the patient is conservatively managed after myocardial infarction or patient is kept in the hospital after any open heart surgery. The typical length of hospital stay is somewhere between 3 to 5 days. If it is coronary intervention like PTCA, patient typically gets discharged on day three, whereas if it is maybe open heart surgery, patient may be kept till day five. But usually for uncomplicated patient, the in-hospital phase duration doesn't go beyond that. Now the challenge is that we have to start with the progressive mobilization during this phase. We have to make sure that patient is able to do all the self-care activities independently without having any complications. So when we are starting with gradual mobilization of patients in this phase, we have to give that activity, monitor, and make sure that there are no any uh, complications or abnormal responses towards that activity which are observed. So the main aim or main goal of phase one cardiac rehabilitation is to minimize the effects of bed recumbency and complications related to the surgery or related to the intervention. Now, related to surgery means whenever it is open heart surgery, um, the pleurae, the mediastinum, the lungs are also handled. The surgery is done under general anesthesia. So there are a lot of pulmonary complications which are involved, Whereas if it is a minimally invasive surgery or coronary intervention, like PTCA, wherein the chest is not or thoracic cavity is not open, patient may not have much of a risk for post-pulmonary complications. So patient will recover much faster. So with respect to whether patient is treated with surgical intervention or a minimally invasive intervention, the complications would depend. But whatever are the expected complications, they should not occur if they are preventable through structured education and structured physical activity that should be achieved. And patient should not have any effects of bed recumbency. And we have to make sure that patient is able to do their self-care activities independently before they get discharged from the hospital. So the challenge over here is we need to balance the optimum healthcare delivery in a relatively shorter duration of time, that is 3 to 4 days. And hence, the early progressive mobilization is the crux of phase 1 cardiac rehabilitation. Uh, so as I mentioned earlier, the first part is the patient assessment, and then we have to go for the progressive mobilization for the patient, which are two aspects of phase 1 rehabilitation. So patient assessment is focused on clearance for initiation for cardiac rehabilitation and identification of the risk triggers, whereas progressive mobilization goals I have already explained. Now, when we are doing patient assessment, first thing is that we need to screen the patient, that who is eligible to receive phase 1 cardiac rehabilitation. So where we can begin with phase 1 cardiac rehabilitation and where we have to wait for some period of time. So this is a AHA risk stratification table, and wherein every patient is can be classified under these four categories. Class A is risk factors may be present, no signs and symptoms are there. Class B is known coronary artery disease or a valvular heart disease or a congenital heart disease, but patient does not have a heart failure. Class C is known cardiac disease is present, but heart failure is there, but it is compensated heart failure. Patient, when we try to load the heart with some physical activity, the heart failure component does not increase. And class D is unstable angina, arrhythmia, or uncompensated heart failure. So in this particular stratification table, class D is definitely a strict no-no for these patients are termed as hemodynamically unstable, and we cannot begin with um, in we cannot give any kind of physical activity in these patients. So we cannot begin with phase 1 cardiac rehabilitation. A and B, we can safely start. C, we can also start, but we will have to be little cautious because this is a risk zone. Okay. So when I begin, if I have stratified my patient, I already know that how vigilant I have to be and in which patients I should not begin with cardiac rehabilitation at all.